Hi everyone. We are, this is the voiceover lecture 1 for Unit 5 Substance Related Disorders, and that's Chapter 15 in your book. Okay, to start off with, we will be talking about substance use disorders, and those would include substance abuse and substance dependence. So first of all, substance abuse. You can see I have the definition down there, but again, maladaptive pattern of a substance, and that leads to significant impairment of stress manifested by one or more of the following. So these individuals will continue to use even though they may not be able to fulfill major role obligations. They may have difficulties carrying out the role of a parent or a student, or carrying out roles of within their job. They also may continue to put themselves in physically hazardous situations, which could be driving under the influence. It could be, getting in fights in bars because they're drunk, that sort of thing, or maybe blackouts. Recurrent substance-related legal problems, so if they're being arrested for disorderly conduct, or if they are being having DUIs. And they continually use the substance despite all those consequences. The DSM-5 would also, it's not necessarily in your book, and you won't be tested on it, but they have also added that the person also has a craving of that substance, and that goes along with substance dependence as well. Okay, let's look at substance dependence. This is physical dependence on a substance evidenced by cognitive, behavioral, physiological signs and symptoms which the individual continues to use the substance despite problems. So if you looked at the substance abuse definition and that criteria, that would also fall into the substance dependence. The only thing is that that substance dependence has those cognitive, behavioral, and physiological signs and symptoms. You need to know the definitions of tolerance and withdrawal, and I think that you guys from your PathoPharm and that sort of thing know that, what those definitions are. So make sure you know what that is. Tolerance, the person just needs more of the substance to achieve the desired effect. So, and then withdrawal, signs and symptoms, that when you lower blood alcohol or lower the amount of the substance in the blood or the tissue concentration, individuals go through a period of signs and symptoms. Okay, substance-induced disorders. First of all, substance intoxication. And we all know basically what that is if we think about alcohol intoxication, but a reversible syndrome of physiological and behavioral changes due to the effects of substances on the person's CNS. And on page 295 in your book talks about essential features that you guys can look at. Substance withdrawal is basically, again, physiological, behavioral, cognitive changes that are a result of stopping the heavy and regular use of a substance. Okay, now we want to look at theories or explanations for why substance abuse or substance dependence develops. One theory is the biological or genetic theory. This focuses more on the dependency as a disease. They are very much use the disease model, and they would say we can call alcoholism or addiction a disease because if we map these out, many of the addictions and alcoholism, etc., goes through specific stages, and we'll look at those stages later. But they also would say that it's a primary disease. It isn't as a result of secondary diseases. They would also say that it's progressive and chronic, and that a person can die from this. Therefore, again, it can fall into that disease model. Also, the fact that it is treatable with medications, with pharmacology, that again would fall into the treatment model or into the disease model. There also is genetic links that many studies have shown there's a genetic link with many of the substances. Now, this can serve some benefits. One benefit of the disease model is that insurance companies are now paying for treatment, paying for medications, paying for going into the hospital for withdrawal, that kind of thing, and that has been good because that has helped with treatment for many people. Insurance companies paying for that. The downside of the biological or genetic theory is that many prescribers or people that treat these individuals will say that that biological model oftentimes will give or can give a person a cop-out or an excuse, saying that, oh, I can't help it, this is just my disease, I don't have any control over it, there's nothing that I can do about it. Okay, so there's it's kind of controversial, but two ways that it can be looked at. The next model, or the next theory, is the psychological theories. There's many out there. The basic things that I want you to know is just that some psychological theories will look at regress development, some will look at poor parenting and psychological problems that are put on because of poor parenting, and there's also some psychological theories that talk about personality traits. People with certain personality traits are more prone to developing addictions. Sociocultural theories really focus on social forces that might be in that person's life, their environment possibly, which might include trauma that has been in the person's life. It might include parenting. One of the things sociocultural will look at is role models. The role models that you're around, you are basically learning from them, and then you imitate what they're doing. So if you have role models that are that drink and or use substances when they're celebrating or when they're sad or as a coping mechanism, that as a child and as you're growing up, or if that's your role model, then you start to develop that as well. Family systems theory is basically based on the systems theory that we talked about before, but that if one part of a system is affected, that the whole system is affected. So family systems theory really looks at if one person has a substance dependency, then many times it's used to serve a purpose in the family. It might be that this person develops addiction or substance dependence to try to maintain homeostasis in the family. So maybe there is another issue, a marital problem, or another burden in the family, and this one person in the family develops an addiction to pull attention away from that issue or to hide that issue. But they really look at roles of family members and how they relate to each other, and also dysfunctional roles. One dysfunctional role that we often see in alcoholism and substance dependency is the codependency role. And codependency, that good definition that's in your book, but basically that there's a codependency between the person who is not addicted and the person who is addicted. The person who is not addicted is often called the enabler. They enable the person who is addicted to continue with that. So for example, you have a husband and a wife, and it may be that the husband is the person who is addicted to a substance. And maybe he went out the night before, got very drunk, and now the next morning he's very hungover, can't wake up, can't get to work, and so the wife may call, or oftentimes will call into work and say, oh, my husband has the flu, he can't make it in today. So that wife is enabling that husband to continue with the disease, or to continue with the addiction, not allowing him to take responsibility for that. And so there's kind of a codependency relationship. The husband depends on the wife, and the wife feels like that she wants to help him, wants to maybe cure him or save him. So there's that codependent type of relationship. There's also, even though AA doesn't really endorse the family systems theory, they do recognize that and believe that the family roles and the dysfunctions of family roles. On page 299, if you look at the dysfunctional family roles at the very top, we see the addict and the codependent, or the enabler. And we see some different roles here, and I want you to know these roles. There's the hero, the martyr, the troublemaker or scapegoat, lost child, and the mascot. Now, I have found that one easy way to remember some of these roles is to think about The Simpsons. Okay, you know, that cartoon, and to try to figure out where would all the different family members fit in these dysfunctional roles. So, the addict, that could be Homer. And who do you think the codependent person is? Marge, right? And then if we looked at the hero or the martyr, okay, that person could be Lisa, often the oldest girl or the oldest boy. Oftentimes can become the caretaker, looking after younger children, making excuses for their parents, maybe even taking care of their parents. Often an overachiever. Okay. The troublemaker or scapegoat, of course, is Bart. Gets into trouble, tries to deflect attention from the dysfunctional family, and starts to become the focus of many of the family's problems, acting out. Okay. The lost child, we could say that's the baby of the family in The Simpsons. That learned to connect emotionally with other individuals, avoids confrontation, withdraws a lot. Oftentimes shows misery by inability to share and development of health problems. Many times becomes sexually active at a young age to get their intimacy needs met. Often the third or middle child, less angry than the troublemaker or scapegoat, but oftentimes more lonely. Now, we do see individuals in a family, sometimes these roles can overlap. So if we look at the mascot, we could say that the mascot also might be Bart. Okay. Okay, we are going to start looking at specific substances now. First of all, alcohol. The effects of alcohol. We know that alcohol is a CNS depressant, therefore a sedative. It's broken down in the liver. We need to be aware of blood alcohol levels and behaviors that occur at each blood alcohol level. So those behaviors can be seen on page 300 in your book in that bluish box, and I want you to know those blood alcohol levels and then what specific behaviors occur at each one. Legal intoxication is, and unless it has changed, but is 0.1, okay? But drunk driving, and again, unless that has changed, but the last time I looked it was 0.08. Now why, again, we can ask the question, why is drunk driving at a lower level, blood alcohol level, than legal intoxication? Well, we can see that at about a 0.08, we can start to have cognitive disturbances. We can have decreased judgment, decreased concentration, which can make driving then potentially dangerous. So just take a look at that. You can see that 0.4, we have a person can go into a coma. 0.5, severe respiratory depression and death. It's very interesting to note at the bottom there when they talk about adolescence that adolescents may not have the exact same behaviors as adults do with their blood alcohol. Oftentimes they don't have that slurred speech, ataxia, drowsiness, and so an adolescent might not even know that they're drunk or intoxicated, and maybe adults won't even recognize that. Okay, and so that may be the reason why oftentimes we see adolescents or young adults, very young adults, become very, very intoxicated and then toxic, and then wind up possibly going into severe respiratory depression and death. Okay, and you guys have probably heard of situations where college students have gone out partying and drinking and have become so drunk, and for whatever reason everybody goes back to their apartment, and then for whatever reason everybody just falls asleep, but the person who has a very, very high alcohol level, nobody's watching out for him, he can't watch out for himself, and may go into respiratory depression and die, or oftentimes they throw up or have emesis, oftentimes will aspirate that, and that may cause death. There's just an incident of a person out in Omaha, a friend of my daughter's, who that happened to last weekend actually, and it was a very, very, very sad situation. He had just graduated from college. Okay, blackouts are also an effect of alcohol. What's the difference between blackout and passing out? Passing out, basically, you just kind of pass out, you fall asleep. Blackouts, we could call those anterograde amnesia. I'm not going to test you on that word, but basically it's a loss of short-term memory. So it's important to ask the person in your assessment, has anybody ever told you that you have blacked out, or have you ever experienced blackouts? And you may need to explain it to them, where you wake up the next morning and don't remember how you got home, or woke up the next morning and you don't remember the night before. Effects of chronic alcoholism. There are two syndromes, Korsakoff syndrome and Wernicke syndrome. First of all, Korsakoff syndrome is a disturbance in short-term memory, and that occurs in people that drink heavily for many, many years and also have a thiamine deficiency. They start brain damage begins to develop in their brain tissue, brain cells, especially in the hippocampus. However, if this is treated very early, it can avoid progression, and we may be able to stop it. But if it starts to become established and more chronic, then oftentimes it is reversible. And the way we treat that is just as early as possible. If we know a person is developing dependency on alcohol, is that we would give them thiamine, either IM or PO. And that's why many times when people come in with alcohol withdrawal or come in intoxicated, many of the standing orders will have IM thiamine given times 3 days, and then maybe put on PO thiamine and vitamins. Wernicke syndrome is alcohol encephalopathy. It's a neurological disease, again associated with chronic alcoholism. This person, common symptoms here are ataxia, nystagmus, and confusion. Nystagmus, you guys should remember what that is, but if you would ask a person to look at your finger and follow it back and forth slowly, you can see, if you look at their eyes, you can see that there is a not, I wouldn't say a tremor, but it's the eyes going back and forth as it's trying to follow that. Again, this would be also related to a thiamine deficiency, and these people with Wernicke syndrome, again, if caught early and acute in the early stages, may respond to large doses of IM thiamine. The next issue that I want to touch on is suicide and alcoholism. Alcoholism and intoxication increase the risk for suicide, especially when it's paired with a loss. Now, why do you think that is? Well, many times alcoholism causes a disinhibition in people. So things that they would never do when they're sober, they might do when they are intoxicated. And then if we think about a person maybe losing a job, getting a divorce, and they're intoxicated, they have a disinhibition, that could maybe cause them to take their own life or attempt to take their own life. And there's been many times when I've worked a day shift and a person has come in the night before, they were very high blood alcohol levels, and tried to do something to kill themselves, either overdose on pills, hang themselves, cut themselves. And then when I talk with them in the morning, many times they will say, "Oh my gosh, I can't believe that I even did that. I really didn't know what I was doing. I would never, intentionally try to kill myself. That's against my religion, and often have a lot of remorse and regret for that. So, but we need to be definitely aware of that combination. Patterns of use with alcohol, page 300 in your book. There's a variety of patterns that people can show. It could be every day they're taking in large amounts. It could be that they only do that heavy drinking on the weekends and limit it. It might be that they have long periods of sobriety, such as 2 or 3 months, but then they might go on a 2 or 3 month binge. So there are a variety of patterns that we should always be asking questions about and assessing. Alcohol withdrawal syndrome starts on page 300 in your book. Now, with alcohol withdrawal symptom, this is when can develop after a person is addicted to alcohol and after they build up a tolerance. Okay, obviously the individual stops drinking, and then signs and symptoms start to develop after the alcohol level drops. We can have minor withdrawal, which I have down there as number 1. If I don't have a number 2, I want you to add number 2. Signs and symptoms can peak anywhere from 24 to 48 hours, and then we have number 3, which is major withdrawal. So let's go back to minor withdrawal. Again, these kind of are fluid, but 6 to 12 hours after the last drink. Some people will say 24 hours. But symptoms that we start to see with this minor withdrawal: person becomes kind of anxious, a little bit agitated, maybe a little bit irritable. Then all of those can start to lead into a person may develop a tremor. Many times start to have increased pulse, tachycardia, hypertension. Oftentimes we just see the beginning of diaphoresis. GI symptoms like nausea and vomiting, diarrhea, anorexia. Okay, this minor withdrawal can last up to 48 hours, 72 hours, but we usually see a peak around 24 to 48 hours after their last drink. Major withdrawal, again, it could start 48 hours to 72 hours. Usually we see that peak around that 48 hours after the last drink. This can be a potentially life-threatening stage because the person very well can develop delirium tremens, and that delirium tremens is marked by hallucinations and then the person developing seizures. And that seizures is where that life-threatening situation can be played out. Major withdrawal also includes increased temperature, tachycardia increasing, hypertension increasing, and basically all the symptoms that I mentioned in that minor and that peak become accentuated and worse. Okay, so you might also see memory disturbances, very much increased agitation, increased hallucinations. Many times the hallucinations with alcohol withdrawal are tactile hallucinations. Oftentimes you will see people complain of, say they just have itching on their skin. Sometimes they'll say they feel like they have bugs or dirt on their skin that they need to get off and they're scratching at. Okay, so quickly, treatment for withdrawal. And just this is kind of where your book touches on it. We're going to do some the following class, do some very specific case studies that have to do with alcohol withdrawal. But here we have monitor fluid status, especially for dehydration. We want to make sure that they're taking in fluids. If they can't drink or if they can't keep anything down, any PO down, then we need to we possibly may need to start an IV. But first we would start with helping them, taking sips of water, maybe sucking on ice chips. But if that isn't allowing drink or allowing them to get fluids, then we may need to start an IV. We often see magnesium sulfate being given, and this is to decrease the irritability of the central nervous system and hopefully to prevent seizures. Vitamin B1 or thiamine and multivitamin is often given. We know that alcohol interferes with the absorption of the B vitamin, and if this continues on for a long period of time, the person is prone to develop that Korsakoff syndrome or that Wernicke syndrome. We will give benzodiazepines in a person who's going through withdrawal, and that is to prevent the DTs from developing and eventual seizures from developing. Those benzodiazepines basically or they are a CNS depressant. Basically, we're substituting one CNS depressant for another CNS depressant. But what we are doing is giving the benzodiazepines because the nervous system is so excitable or so irritable when the alcohol starts to go out of the system that we are basically putting another a small amount of CNS depressant in to prevent those seizures. And then we keep that central nervous system calm until the withdrawal is gone. Okay, and then we can take them off the benzodiazepines. After the person has detoxed, there are a couple of medications that we can give. One is Antabuse, and this prevents alcohol from being absorbed. Basically, it's allowing acetaldehyde to accumulate in the brain, and a powerful reaction can occur that causes nausea and vomiting, and it's kind of a deterrent. Okay, if a person is on Antabuse and they drink alcohol, they can have a powerful reaction that causes nausea and vomiting, can become very sick. Naltrexone is another medication, and this basically decreases the cravings for the individual, and then hopefully will block that need or that craving for alcohol and will keep them away from alcohol. So when we talk about early detection of alcoholism or drinking, it's very important that we always ask the patient, when was your last drink? Again, so that we can start to predict when they start to have beginning symptoms, when they're going to have a peak of symptoms, and when they possibly may have major withdrawal symptoms, and then we can be prepared for the possibility of a person having hallucinations, going into DTs, and having seizures. Okay, the next substance that I want to talk about is narcotics or opiates. Opiates in a natural form is opium, heroin, morphine from the poppy plant. Synthetic opiates, I have written down there methadone, oxycontin, etc. Codeine. Many times you will see people on pain medications that have synthetic opioids in them, such as, like I said, oftentimes, after, I just can think of many people who have had ACL, knee injuries, and they're put on, some of these medications to deal with the pain afterwards. Many times people are on these medications also for chronic pain, but just to be aware that these are addicting as well, and when a person comes off these medications, depending on if a tolerance has been built up, they can also develop withdrawal signs and symptoms. Effects of opioids, intoxication, I have down there what those symptoms are. The person has a euphoria or a high. Many times they appear drowsy, out of touch. An overdose, this person becomes unconscious, pinpoint pupils, very shallow, slow respiration, start to get below 10, pulse below 40. Also, not just the drowsiness, but that leads to that unconsciousness. Treatment for overdose is Narcan or naloxone. This is a narcotic antagonist which counteracts that respiratory depression. Maybe you guys have been seeing what's been in the news, what has been trending. Many of you heard about the talk about that they want to push to have naloxone available to first responders and possibly to family members, or those people that are most likely to be around somebody who might OD on opioids and basically heroin, and so that we will cut down on the amount of deaths because of heroin overdose. Withdrawal from opioids, early symptoms are muscle aches, restlessness, anxiety, tearing eyes, runny nose, almost like they kind of have the flu, sweating, inability to sleep. Later signs and symptoms can be diarrhea, abdominal cramping, nausea and vomiting, this goosebump feeling, rapid heart rate, increased blood pressure. And if you think about all those symptoms, those are so just a miserable withdrawal that is what really causes a person to go back out and to look for more heroin or look for more opiates to get rid of all those, kind of miserable symptoms there. Usually at about 48 hours we see the peak of the withdrawal, but withdrawal actually can last for 2 weeks. And many times after those beginning symptoms are over, the patient is very much craving the drug. We often see babies who are born to mothers who are addicted to opioids. And those babies have digestive issues, have poor feeding, may not be able to latch onto a nipple. They show dehydration, vomiting, and also seizures. Treatment for opioid addictions is Suboxone, and that is also an opiate, but it's not as addictive, so it's less likely to be abused. And basically what this is doing is treating the signs and symptoms of withdrawal, but has a shorter intensity. Okay, we also can use methadone, which is a synthetic narcotic, and this is long-term maintenance. They're usually on a long-term maintenance program. And methadone, it keeps the withdrawal signs and symptoms away, but the person does not have the rush or the high. And basically it's blocking the action of the opioids. It decreases craving. So you will see people on methadone programs where they may go to a clinic and get methadone, and usually that's given out every day. So there's some controversy that surrounds the treatment of these individuals with methadone, but I'm not going to get into that now, but just be aware of that. You also might see clonidine being given for treatment of withdrawal. Clonidine basically blocks withdrawal symptoms, makes the detox less painful. You also may see a person being given Lomotil or Bentyl for the diarrhea, that symptom that they're having. Okay. Another possible substance that can be abused and a person can be addicted to is benzodiazepines, which again I already mentioned that in withdrawal of alcohol, but is a CNS depressant. Some examples of that is Xanax, Librium, Valium. We'll talk about that later when we get into anxiety disorders. I'm not going to get into that now, but just know that that's a drug that can be a prescription drug that can be abused. Cannabis is the next slide. Cannabis. Effects of cannabis. We know that obviously cannabis contains the chemical THC, which is found in the hemp plant. THC can be stored in the fatty tissue of the body, and so oftentimes can be detected in the body up to 6 weeks. But a lot of times that depends on how long they've been using and how much THC they've been using. Many times people will say that THC can be in a person's hair up to 3 years. Analgesic has a lot of different effects. We know also that with different studies that there is some analgesic effect for some individuals and can help with some nausea and vomiting associated with various types of chemotherapy. Patterns. Chemical to there a lot of times we talk about, oh, nobody can get addicted to marijuana, there's no way that's possible, but chemical dependency can develop. Now in adult it might take 10 to 15 years, which actually is a pretty long time, but they can become chemically dependent. For children or adolescents it may only be a few years and they can become chemically dependent. One of the dangers with adolescents and children using marijuana is that it has an effect, and they're doing more and more research and showing more evidence that it does have an effect on the development of the brain. And when you think about the development of the brain, can take as long as into a young adulthood, 24 to 26 years old. And if cannabis is used on a long period of time, that it actually, or it can cause problems with development. I want you to know on page, excuse me, 309, I think it is, where it talks about the dangers of marijuana. Excuse me, I'm going to... I want you to know those and to kind of look at that. You can see that it talks about marijuana individually, but it also talks about the marijuana smoke. The next slide we have here are stimulants, amphetamines, and cocaine. Stimulants, we're talking about amphetamines, methamphetamine, speed. We know that this obviously is a CNS stimulant. Oftentimes is used in like a binge and crash pattern. Bath salts or bath salts derivative is very similar to amphetamines. Effects of amphetamines: agitation, paranoia, all of those things that I have down there, increased vital signs. Long-term effects: definitely a neurotoxin, and therefore a person can develop neurological damage like cognitive changes, cognitive disorders. They also can develop skin lesions and hypertension. There's a good picture of a person on page 308, somebody who has been addicted to some of the methamphetamines. That's the basic stuff that I want you to know about that. As we go on, I'm not requiring as much, but just kind of mentioning some of these drugs and just having you kind of be aware of them. Cocaine also is a CNS stimulant, can be physically and psychologically addicting. Many times once tolerance has started to develop, they no longer get a euphoria, but they can't stop taking it because they want to avoid those withdrawal symptoms. The alcohol or the withdrawal, very similar to alcohol withdrawal. And they can also develop post-cocaine blues, where a deep depression can set in after they have withdrawn. Patterns of use: we know we can smoke cocaine, inject cocaine, snort it. Can be very expensive, although it's getting cheaper and cheaper actually, and especially when you go to crack cocaine. Treatment: the variety of treatments. I'm not going to test you on that, but if you had a patient who was going through cocaine withdrawal, you could look up protocols, or there would be specific protocols for that treatment. I'm sure you guys are aware of the legal stimulants that are out there: nicotine, caffeine, dexedrine, and Ritalin. And many times those are used with ADHD. Club drugs, I'm not going to be going into, but those are some of those club drugs: hallucinogens, sorry about that, LSD, PCP. One thing that we're not going to spend very much time talking about, I would love to if we had more time, is what we call process addictions. And those would be addictions that aren't chemicals, but they are such as porn, shopping, gambling, video games, internet addictions. And research and study has shown that many of these process addictions affect the same areas in the brain and can cause addiction as well. Groups at risk: if you think about, we have the really obvious groups that are at risk for substance abuse or addiction. Teenagers, of course. Many times psychiatric patients are at a higher risk for substance abuse disorders. Many times they will use substances like marijuana or alcohol to medicate some of their symptoms, like the voices, like delusions, that sort of thing. Women are at a higher risk than men. Generalized hospital patients also. Older adults, which you wouldn't necessarily expect, but older adults are at a higher risk just because of the losses that they're going through. Adult children of alcoholics have an increased risk, and healthcare providers. So you and me, okay, when you guys graduate, we are going to be at a higher risk for addictions. And why is that? Kind of think about that. Mainly because we have more access to drugs and controlled substances, so that puts us at a higher risk. And also because being a healthcare provider, being a nurse, that can be a very stressful job day in and day out. And so sometimes if we don't have proper coping mechanisms, if we don't have proper balance in our life, that puts us at higher risk. Okay, this is where I'm going to stop, and we will continue with the nursing process with substance abuse and addictions at our next time that we get together. Thank you.